Hello guys, welcome to another video of the host of Pharmacology series. Today we'll be talking about opioid analgesics. And again, this is for any pharmacology because there's a lot of overlap, but this is the HOSA pharmacology event overview. It's different for every pharmacology event, but either way, any pharmacology, I'm the guy. Anyways, this is just a little breakdown of everything. Okay, first of all, what is an opioid? An opioid is a class of drugs, like any other class, like NSAIDs or salicylates, that bind to opioid receptors in the brain to produce an analgesic effect. Remember what we learned earlier? Literally, like last video. Analgesic is pain relieving, as well as antipretic, analgesic, you remember that? Antipretic, and analgesic, anti-inflammatory, that stuff. Okay. Anyways, analgesic. There are three main ones. You don't really need to know about which type of opioid they are, just that it is an opioid. Morphine, codeine. Okay. So that's what an opioid is. It binds to the brain to produce a pain relieving effect. Okay, basically the mechanism of action of opioids is that they bind to the mu opioid, and kappa opioid receptors in the central nervous system, or CNS. And the CNS has opiate receptors that attract the opioids and give the analgesic or and sedative effect. It also gives euphoria, cough suppression, and respiratory depression. So basically just makes you feel like you're sleeping, if you know, like it's like that, euphoric, like kind of dreamy state. But if you look at the slideshow, you would see, strong analgesic effect. And yeah, this is the more in-depth mechanism of action on how it actually affects it. But all you have to know is that the opioids attract and go into the mu and kappa opioid receptors to produce that, euphoric, sedative, analgesic effect. We'll talk about this respiratory depression stuff and moisis later. Moisis. Oh, I don't know what I'm saying. Oh, what's going on? Let me fix that. Okay, so the next slide is the opioid classifications. There are three main ones: full opioid analgesics and the partial agonists. Agonist and agonist. Agonist, if you didn't know, is just like it goes into the receptor and produces the effect. And an antagonist means it goes into the receptor and cancels the effect. So agonist means activates effect, antagonist means cancels effect. So opioid agonist means it produces an opioid effect, and partial agonist means it produces a half and half effect. If you see, some of our common ones are morphine, fentanyl, oxycodone, hydromorphone, methadone, codeine. We've all heard of morphine and fentanyl. As you can tell, fentanyl very, very strong, which is why it's a full agonist. And a partial agonist is like this. I don't even know how to pronounce that, but it's partial. And then mixed agonist antagonist. You don't really have to know these. I'm completely forgot why I kept it on there. But basically, these two you have to know: full agonist, partial agonist, and what they do. Okay, next up is the adverse reactions and adverse effects of opioids. Okay, so if you can see, the common ones are sedation, and nausea, but you know, that's basically just the what we want. This is the intended effect: sedation and drowsiness. That's what we want. Moisis, pinpoint pupils. That's an adverse reaction, but that's not really that harmful. But this is what you have to really pay attention to. I'm probably going to post another video on this. Basically, respiratory depression is the main like adverse reaction of opioids. It's when the person who took the opioid is breathing too slow. And if you see here, if their breaths are under 12 breaths a minute, that's extremely slow, and it's life threatening. Some other ones are, nausea, vomiting, sedation, dizziness, confusing, constipation, urinary retention, hypertension, moisis, you know, and all that stuff is common. But basically, despite all this, the main big one you should, if anything, you should remember is that respiratory depression is the main adverse reaction of opioids. Also, I don't know if I talked about this earlier, but the uses for opioids are moderate to severe acute pain or chronic pain, cough suppression, and severe diarrhea. And just they're used in anesthesia, which I will go into next video. Some common opioid analgesics, I'll go over this quickly, are morphine, oxycodone, fentanyl, and codeine. If you see a common thing in between all of these is that they're all Schedule 2 controlled substances. If you don't know what that is, search it up. But basically, under the Controlled Substances Act, there is a list of substances, of scheduled substances, 1 to 5. 1 meaning the worst, like the most addictive drugs that aren't even used in the medical field because of just how bad they are. And Schedule 2 is, second bad. They're very bad and addictive, but they are not that bad that they're used in the medical field. And then, as you can tell, Schedule 3 is a little worse, Schedule 4 is a little less addictive, and Schedule 5 is, not that bad, like benzodiazepines, which isn't that bad. If you see, most of the opioids are full agonists, meaning that they have a full effect. And yeah, they're all slightly different from how long they last to, what routes they're used in. You can see these ones are morphine is given in almost all the routes, while oxycodone is orally, which is PO. Okay, so now we know what opioid analgesics are. Let's talk about opioid antagonists. Okay, basically, opioid antagonist is something that counteracts the effect and action of an opioid. And so, opioid antagonists reverse the effects of an opioid. The main one is naloxone and naltrexone. There are more, but no one really uses those. Basically, they both reverse opioids, except here's the main part. The reason why naloxone is used so much more than this drug is because if you look here, this one is used for emergency opioid reversal. Narcan or naloxone is a fast acting emergency reversal agent for active opioid overdoses. So, and the thing about naltrexone is that it's a long term medication used for long term treatment of alcohol or opioid addiction. That's why when people say if you see somebody who is going through respiratory depression and is overdosing, you should give them naloxone because it only takes 1 to 5 minutes before the Narcan kicks in and they're coming back. Which is why if you have like a presentation at your school about opioids, they talk about naloxone and Narcan being readily available, not Vivitrol and stuff. Sorry, I'm new to this new YouTube thing, but basically I missed something in the adverse reactions. You shouldn't use opioids with any other type of uh like CNS stimulant like alcohol and that stuff because it can lead to a higher risk of respiratory depression. Also, you shouldn't use this when you have respiratory diseases like asthma or COPD. Definitely not in pregnancy, and not if you're an elder or have renal and hepatic or liver and kidney impairment. And this will seem like as common sense, but I just want to remind you, like, keep this in the back of your head. Okay, one last thing before we go to the review page. Naloxone or Narcan, I'm just calling Narcan. Narcan, after you use it, it's not like a cheat or a hack to get out of your opioid addiction. Once you administer Narcan, you need to get them to the hospital for better treatment since it only lasts like 1 hour or so. But even after this, you will have an acute withdrawal in opioid dependent patients. So once you administer Narcan, after that effect wears off, they will still feel like they are like wasted. Like they will need more opioids, which is why you have to take them to the hospital. So yes, Narcan does still has withdrawal symptoms after you use it. Anyways, this is the review page and the key takeaways. These opioid analgesics act on the mu opioid and kappa opioid receptors. There are full agonists and partial agonists. And key thing for nurses is that they have to monitor the respiratory status to make sure the patient doesn't go into respiratory depression. Naloxone is for emergencies. Naltrexone is for long-term therapy. And yeah, no analgesic effect. I took this information from Moyni and Ford's book, which you should be using for studying for HOSA. And honestly, they're not bad for general pharmacology practice either. Anyways, thank you for watching. See you guys in the next video.